Executive Fellow in Education at APHA. In today's episode, we're diving into the 2025 ACC, AHA, ACEP, NAEMSP, and SCAI Guideline for the Management of Acute Coronary Syndromes, or ACS, and exploring the pharmacist's expanding role in implementing evidence-based cardiovascular care. From optimizing dual antiplatelet therapy, or DAPT, to ensuring access to lipid-lowering agents in cardiac rehab, pharmacists are uniquely positioned to close care gaps and improve long-term outcomes in ACS. Before we dive in, I'd like to introduce my guests today, Katie Meyer and Neha Devlekar. Katie and Neha, why don't you introduce yourselves?
Well, hello there, Yara. Thanks so much for having me. My name is Katie Meyer, and I serve as the Senior Director of Content Creation at APHA. I'm excited to be part of this.
Yeah, hi Yara. Thank you for the introduction. My name is Neha Devliker. I am the Safety Net Health Equity Fellow with NovaScript Central and the American Pharmacists Association.
Thank you both for being here. So let's dive in. Katie, let's start with DAPT. When a patient is discharged after ACS, what do pharmacists need to know to provide the best recommendation possible about DAPT?
Sure, Yara, of course. So, DAPT is still the go to after ACS, and guidelines still recommend aspirin plus a P2Y12 inhibitor. Appropriate dosing of oral antiplatelet agents is essential for optimizing outcomes and minimizing risk, and they should be initiated in patients with ACS as soon as possible. Aspirin remains foundational, starting with a loading dose of 162 to 325 milligrams, preferably non-enteric coated and chewed for rapid onset, followed by a daily maintenance dose of 75 to 100 milligrams. In addition to receiving aspirin, patients with ACS should be treated with a loading dose of an oral P2Y12 inhibitor, followed by daily dosing. For clopidogrel, a loading dose of 300 to 600 milligrams is used for non-ST elevation ACS or STEMI without fibrinolysis, followed by 75 milligrams daily. However, with STEMI and fibrinolytic therapy, a 300 milligram loading dose is recommended if the patient is less than or equal to 75 years old, while older adults should begin with just 75 milligrams without a loading dose. Prasugrel is reserved for patients undergoing PCI and not receiving fibrinolytics. The loading dose is 60 milligrams, followed by 10 milligrams daily if the patient weighs greater than or equal to 60 kilograms and is under 75 years. For lower weight or older patients, 5 milligrams daily is advised, though caution is warranted due to increased bleeding risk. Ticagrelor, another preferred agent for DAPT, is initiated with a 180 milligram load, then continued at 90 milligrams twice daily. There are several considerations to keep in mind when selecting a P2Y12 inhibitor. These depend on the clinical setting and patient-specific factors such as age, weight, kidney function, or bleed risk. Certain agents may be preferred over others. As pharmacists, we play a critical role in confirming correct doses, adjusting therapy, counseling patients on adherence and side effects, and ensuring that the best agent is selected based on each individual patient's circumstance. We can also be alert for medications that might increase bleeding, like NSAIDs or SRIs, and talk to the team if adjustments are needed. And lastly, we can make sure patients actually understand why they're on to antiplatelets, what signs of bleeding to look out for, and what to do if they miss a dose. And don't forget those 3 to 6 month check-ins. Some patients might need to shorten or extend DAP, and pharmacists can help bring this to the table.
Thank you, Katie. That was very valuable. And now, what about duration? How to help personalize DAPT beyond just 12 months for everyone?
Yeah, so that's where the 2025 guidelines add value. It shifts from that prior mentality of 12 months for everyone to individualized durations. Now we're looking at tools like the Academic Research Consortium High Bleeding Risk, or ARC-HBR, to guide clinical decision making based on bleeding risk. The ARC-HBR is a clinical risk tool developed to help healthcare providers identify patients at high bleeding risk during or after percutaneous coronary intervention, especially when considering DAPT duration. A patient is considered high bleeding risk if they meet at least one major criterion or two minor criteria as described by the ARC-HBR tool. Major criteria include conditions strongly associated with serious bleeding complications, such as the use of long-term oral anticoagulation, so a warfarin or a DOAC, severe or end-stage chronic kidney disease with an eGFR of less than 30 mils per minute, recent major bleeding, so especially gastrointestinal or intracranial within the past 6 months, hemoglobin levels below 11, and platelet count below 100,000 or active cancer. Minor criteria reflect more moderate but still clinically relevant bleeding risks and include age greater than or equal to 75 years, moderate chronic kidney disease, long-term use of NSAIDs or steroids, prior stroke beyond 12 months, and mild anemia. These criteria help assess bleeding risk, which informs decisions about the duration and intensity of DAPT therapy following ACS and PCI. While ARC-HBR doesn't directly dictate therapy duration, it informs guideline recommended decisions. Pharmacists play a critical role in using this tool to identify and document bleeding risk during medication review and transitions of care, as well as educating high-risk patients on the importance of adherence, recognizing signs of bleeding, and ensuring appropriate follow-up and monitoring is conducted.
Neha, the 2025 ACS guidelines take a stronger stance on LDL targets and stepwise lipid lowering. Can you walk us through how the new recommendations guide therapy selection for different patient scenarios and how pharmacists can support these decisions in practice?
Sure. So, this is actually the first comprehensive guideline released for ACS as a whole. Previous guidelines were published separately for STEMI and NSTEMI, with the last updates dating back to 2013 and 2014. These new guidelines incorporate insights from the 2023 chronic coronary syndromes management recommendations, so it is fair to say that a unified, updated framework has been long overdue. One of the key takeaways from this guideline is a stronger focus on treat to target LDL strategies. High intensity statins are still the foundation, like atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams daily, but the guideline now gives clear thresholds on when to add non-statin agents like ezetimibe, PCSK9 inhibitors, inclisiran, or bempedoic acid if LDL-C remains above goal. When looking at adding non-statin therapies to a maximally tolerated statin regimen, ezetimibe is often our first go-to, and in combination, it lowers LDL by 15 to 25%. If more LDL lowering is needed, PCSK9 inhibitors like alirocumab or evolocumab can lower LDL by around 60%. Inclisiran is a newer agent inhibitor taken every 6 months and lowers LDL by about 50%. And finally, there's bempedoic acid, which lowers LDL by about 20% and can be useful in statin intolerant patients. The guidelines also provide flexibility in how to approach different clinical scenarios, such as patients who are statin naive, statin intolerant, or already on a maximally tolerated statin dose, but not yet at LDL-C goal. So let me walk you through a patient case to illustrate all of this. So let's say patient X is admitted with a myocardial infarction and receives a stent placement. As Katie mentioned earlier, they are started on DAPT, and the next step is optimizing their lipid lowering therapy. If patient X has not previously been on a statin, they should be initiated on a high-intensity statin, such as atorvastatin 40 to 80 milligrams once daily or rosuvastatin 20 to 40 milligrams once daily. Now, let us say the patient has already been taking atorvastatin 80 milligrams, and this is now a secondary coronary event. And despite therapy, their LDL-C remains elevated, say between 85 to 90 milligrams per deciliter based on recent labs. In this case, the guidelines recommend adding a non-statin agent such as ezetimibe, PCSK9 inhibitors, inclisiran, or bempedoic acid. This approach also applies if the patient's LDL-C levels remain between 55 to 69 milligrams per deciliter despite being on maximally tolerated statin therapy, or if they are statin intolerant. which is defined as intolerance to at least 2 different statins, including one at the lowest available dose. Following any initiation or adjustment of lipid-lowering therapy post-ACS, a fasting lipid panel is recommended within 4 to 8 weeks to assess treatment response. Post-ACS, the ultimate targeted threshold for LDL-C is less than 50 milligrams per deciliter. Given that the risk of major adverse cardiovascular events, also known as MACE, is highest in the early months post-ACS, early follow-up visits are essential to monitor progress and make timely adjustments in therapy to help patients reach their LDL-C targets.
Now finally, Neha, for secondary prevention, what are some ways pharmacists can step in after initial hospital discharge?
Absolutely. So this is a very robust topic, but according to the new guidelines, aggressive LDL-C lowering is a key component of secondary cardiovascular disease prevention. For context, every 1 millimole per liter, which is approximately 39 milligrams per deciliter reduction in LDL-C, is associated with approximately a 22% relative reduction in cardiovascular events over a period of 4 to 5 years. This highlights a critical opportunity for pharmacists to intervene post-discharge. One of the most impactful ways we can contribute is by monitoring and optimizing statin therapy. And that includes reviewing discharge prescriptions for appropriate statin intensity, identifying any gaps in therapy or inappropriate dosing, communicating with providers to align with guideline recommended statin regimens, especially for patients recovering from an ACS event. This role is particularly important during transitions of care, as an ACS is often a life-altering event. Pharmacists are well positioned to step in and address common misconceptions and stigma surrounding statin use, and providing education and counseling at this vulnerable time can help patients understand the life-saving benefits of statins in secondary prevention. The guidelines also recommend that if a patient experiences adverse effects from a statin, clinicians should consider rechallenging the same or a different statin at follow-up visits, or even switching to another class of lipid-lowering agents. Statin rechallenging should be individualized for each patient and may involve adjusting the regimen. For example, taking it every other day instead of once daily, switching to a different statin, lowering the dose, or gradually titrating to the maximum tolerated dose, or reintroducing the statin after a drug holiday to assess tolerance. This approach is important given the substantial long-term cardiovascular benefits of statin therapy, and pharmacists play a vital role in this process, especially because patients often self-discontinue statins without notifying their care team. Acting as a liaison between patients and providers, pharmacists can help ensure that lipid-lowering therapy is not only initiated but also sustained over time. Additionally, pharmacists can make a big impact by helping ensure that patients with comorbidities like type 2 diabetes or heart failure are started on an SGLT2 inhibitor or a GLP-1 receptor agonist, because beyond glucose control, these medications have proven cardiovascular benefits that can reduce the risk of future events in patients with ASCVD. In addition to medication management, the guidelines recommend that patients be referred to cardiac rehabilitation prior to discharge. And this rehab is not just about exercise, it offers structured support for lifestyle changes, medication adherence, and psychosocial health. Pharmacists can reinforce the value of rehab during early follow-up and help ensure patients follow through with enrollment. Core components of cardiac rehabilitation include patient assessment, counseling on nutrition and physical activity, management of weight, blood pressure, lipids, diabetes, and psychosocial health, tobacco cessation, and supervised exercise training. Many of these areas can be revisited and reinforced during pharmacy visits, particularly for patients actively engaged in rehab or prescribed medications consistent with secondary prevention. Evidence shows that patients in cardiac rehabilitation tend to have better outcomes. And finally, I want to highlight the role of vaccines after an acute coronary syndrome. The guidelines recommend a yearly influenza vaccine for patients without contraindications, and that is because influenza infections have been shown to trigger plaque instability and increase the risk of another cardiac event. So, vaccine administration is important to reduce risk of death and MACE in these patients. Pharmacists should take the lead in ensuring their post ACS patients are getting their flu shots. And while there is not enough randomized trial data to support routine use of other vaccines at the time of ACS hospitalizations, patients should still follow regular CDC recommended immunization schedules unless contraindicated.
Thank you both, Katie and Neha, for such a practical, engaging discussion on the 2025 ACC AHA guidelines and how pharmacists can make a difference in the care of patients recovering from ACS. To wrap up today's episode, pharmacists play a critical role in optimizing DAPT post ACS by confirming appropriate drug selection, dose, therapy duration, and supporting patient education. The 2025 guidelines emphasize individualized antiplatelet duration using tools like the ARC HBR to assess bleeding risk, something pharmacists can actively contribute to during med reviews and discharge planning. When LDL levels remain above goal, pharmacists can support stepwise lipid lowering therapy using statins and non statin agents based on the clinical context. And finally, for secondary prevention, pharmacists ensure continuity, reinforcing rehab enrollment, lifestyle counseling, and lab follow up. All right, folks, that's all the time we have for today. Look out for part 2 of this month's First Fill podcast that will be released next Thursday. And don't forget to collect CE credits through the Learning Library at pharmacist.com. We'd love your feedback on this episode, and we'll see you next time on the First Fill. Take care.